The next topic is chaired by Dr. Jayaprakash S., Professor of Cardiology, Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. Dr. N. Hegde, Professor of Medicine, Father Muller Medical College, Mangalore. Dr. Sadananda Naik, Consultant Physician, Mudabidri. I invite the chairpersons to kindly take their seats.
I request him to give this very important talk because there are certain things which we should not treat, even though it is there. So, Dr. Martin Green.
Thank you. There will be some overlap with the previous talk and some other talks, but I think it's an important consideration that we do not necessarily treat arrhythmias. What we're treating are either symptoms or risk. So we don't actually look at an ECG, see a PAC or a PVC and say this requires treatment. What we have to do is say what is the symptomatic goal in this. Am I going to make the patient feel better, or am I going to somehow reduce their risk? You have to answer either or both of these questions with a yes before you consider treatment. Either you're going to make them feel better or you're going to reduce their risk. Those are the only two reasons, not just to make their Holter or their ECG look better. Okay, so let's talk a bit about some of the arrhythmias or the arrhythmic substrates where we would consider not treating people. Okay, oh, sorry. So here is a Holter monitor on a 42-year-old man who has some intermittent palpitation. Have a look at this. What we see is a sinus beat conducted, a sinus beat conducted with a very long PR interval, and a sinus beat blocked. And then a repeat here, sinus beat conducted, blocked, and then a junctional escape, and then a very long PR interval. So this is second-degree AV block. Does this person require treatment? Again, we have to ask the question, is there a risk or are there symptoms associated? So let's have a closer look. The single most important thing on this strip, I didn't show you. The single most important thing on this strip is this. This occurs at 3:20 at night while the patient is sleeping. This is a normal phenomenon, especially in young, healthy people, especially in athletes, especially in fit people. Wanky back, even complete heart block at night can be totally normal. So we don't treat wanky back. What we do is we assess, is this related to the patient's symptoms? Are we likely to do anything that's actually going to reduce their risk? Wanky back is extremely common in fit people, especially during sleep. 3:20 at night, wanky back, a normal phenomenon. So the second one, well, I won't go so much into this because we've just heard a talk on this with ventricular ectopics, but I think it's important to realize, so this particular person, a 55-year-old man who has palpitation, what does he have on the ECG? Well, he has ventricular bigeminy. He has sinus, oh, I went backwards, sorry. Sinus rhythm, a sinus beat followed by a PVC, a sinus beat followed by a PVC, sinus beat, PVC, sinus beat, PVC. So what we also see is that the sinus beats are normally conducted and the ECG is completely normal. Now that obviously doesn't rule out some disease, but this is a very typical outflow tract PVC. This is the most common cause of PVCs, and they are usually benign. You do have to ask the question, is there structurally abnormal heart? In the case of a structurally abnormal heart, we still don't necessarily treat the arrhythmia, but we may assess their risk. If the arrhythmia is asymptomatic, then for this patient had palpitation, but if the arrhythmia is asymptomatic, we're not treating the arrhythmia. We're trying to assess what is the risk, and is there something we can do that will reduce the risk. Now, in this particular case, and I won't spend a lot of time on this. You see, I just want to point out that you see in V3 that we have a transition of the PVC that is predominantly positive, whereas the sinus conducted beat is predominantly negative. So the transition of the PVC occurs before the transition of the sinus beat. And this typically is the left ventricular outflow tract, despite the fact that it has a left bundle branch block morphology. So this actually may come from the aorta. There are muscle fibers in the aorta that can produce these PVCs, and in the left ventricular outflow tract, despite the fact that the PVC in V1 has a left bundle branch block morphology, this likely comes from the left side. Probably left ventricular outflow tract. We go through the same process. One thing I will add to Jayaprakash's statement is we do look for sarcoid in people with some atypical or multifocal PVCs. And I think you nicely mentioned the MRI, but one other test we do for sarcoid now, if you have it, is PET scanning, because it will light up on a PET scan if you have active cardiac sarcoidosis, occasionally even with the MRI being normal. Okay. These PVCs are benign in the absence of structural heart disease and require only symptomatic therapy, which is usually just beta blockade. So, here's a patient who actually has syncope, 32-year-old man with syncope. Do I panic? Does this patient require a pacemaker? Well, he clearly has heart block. We see sinus rhythm, and then we see a few sinus beats that are blocked, and then we see sinus arrest. Does this person require a pacemaker? We get referred these people for pacemakers all the time. Should I panic? Who's going to answer for me? Maybe I should panic. Don't panic. This is typical vasovagal neurally mediated syncope. They almost never require pacing. You need to instruct them on keeping volume status normal. You need to instruct them on the situations when they have their syncopal episodes. You need to instruct them when they get their premonitory symptoms that they have to lie down. They have to lie down with their feet up, and they can almost always abort these episodes. These patients almost never require pacemaker therapy. This is a lifestyle therapy. The one thing that's the tip-off that this is neurally mediated or vagal is not only do we have heart block, but we have heart block at the time of sinus slowing. So what we see here is the sinus slows, it slows even further, and we have sinus arrest at the same time as heart block. So this is a very good evidence for a hypervagotonic state, not conduction disease. And these people almost never require pacing. I wouldn't say never, but almost never require pacing. So you have to look carefully and ask yourself the question. This is neurally mediated vasovagal syncope. It is usually benign and can be looked after with lifestyle measures without pacing. Sinus bradycardia becomes slower at the same time as heart block occurs, which is evidence of enhanced vagal tone. Not all heart block is due to conduction disease, and there is no indication for pacing in the vast majority of people with neurally mediated syncope. So, another case. Here's a 56-year-old man who got an implantable loop recorder for syncope. 4 months after getting the implantable loop recorder, he has a syncopal episode, and here's the strip. This is sinus arrest. So here we see sinus rhythm, slowing, and complete sinus arrest. Again, this is neurally mediated syncope. You have to take a history. These people almost never require pacing. They usually have premonitory symptoms. You usually can tell them by maintaining their fluid and salt status and blood pressure that these things can be aborted. So not all sinus pauses are sinus node disease, and pacing is usually not required for these people. Again, I would never say never, but is usually not required. So here's a 24-year-old woman with syncope, comes to the emergency room, and while lying in the cot in the emergency room on the monitor, this is recorded. they called cardiology immediately because of polymorphic VT. What do? The answer is put the leads back on a little bit better. This is, we learned about this yesterday. This is artifact. We can see how the baseline, we lose it here despite the fact that there is clearly a QRS which falls on time. Another one, another one, another one. We see a typical QRS in the middle here, and this, when we walk through it, we see that all these, including this one, we can see that they fall on time. It leaves us with a couple of question marks, but there are undoubtedly QRSs there and there, as we would expect. You can walk it through. This is artifact. This is a loose lead. Lead got jiggled. The patient was asymptomatic at this. This requires no therapy. It only requires a little thoughtful ECG inspection. Here's another one. This one was sent to me, believe it or not, from Australia. Physician in Australia says one of the physicians wants to put a defibrillator in this person. 44-year-old man with lightheaded spells. Should I panic? This is a beautiful ECG because they didn't at the time recognize that lead 1 and lead 2 are recorded simultaneously. And we see that lead 1 has a absolutely perfectly normal sinus with normal conduction at the same time as all this junk is being seen in leads 2 and 3. So what does it mean? It means that the right arm and the left arm are both good, but there's something wrong probably with the left leg, and it was wiggly and jiggly. This is another example of artifact, and this is one of the ways you recognize it. And this patient almost ended up getting an ICD. Don't panic. Look at the ECG. Beware of artifact. Look for the telltale signs of the QRS. Lead 1 stays normal. Therefore, it is a left leg problem. Now, we talked about this one already, but this is a right ventricular outflow tract tachycardia, but this is VT now, not just PVCs. And again, the question is, why am I treating this patient? If their heart is structurally normal, and this is the typical ECG of a structurally normal heart, am I treating them for symptoms or am I treating them for risk? There is no evidence whatsoever that we're going to reduce their risk with any treatment. So the only reason to treat them is symptoms, and usually a small dose of beta blocker or occasionally nothing. Many of these patients have symptoms that go on for a couple of months, and they may go away for months or years on end. I usually tell them at some point in time it'll come back, and after that it'll probably go away again. If they have relatively little symptoms, by the time I see them, it may be 2 or 3 or 4 months after they get referred, and their symptoms are totally gone. We don't necessarily have to do anything for these people. Typical RV outflow tract VT. Don't panic. They require no therapy, and this is the most common form of PVCs in the normal heart. Even the VT is benign when the heart is structurally normal, especially in this particular case. Often respond, and sometimes their symptoms are not just palpitation, but they have been told that they have ventricular tachycardia, and this is very dangerous. And what they require is reassurance more than anything else. Catheter ablation is very effective if the patient is symptomatic. I want to spend a bit more time on this one, because here's a 72-year-old woman with coronary disease, previous bypass surgery, who comes for a routine visit and is asymptomatic, and she has atrial fibrillation. So I'm here to talk about, first, do no harm. What arrhythmias can we not treat? And atrial fibrillation, she's totally asymptomatic. I have to ask the question, am I going to make her feel better by maintaining sinus rhythm if she's completely asymptomatic? No, but I can certainly make her feel worse. Am I going to reduce her risk by treating her atrial fibrillation with some form of antiarrhythmic therapy or cardioversion? No, because her risk is what? Her risk is thromboembolic risk, not related to her atrial fibrillation. So she may have asymptomatic atrial fibrillation even after I cardiovert her. So if we look at her risk, it's really related to what's her risk of thromboembolism. really not her atrial fibrillation. So the therapeutic goal should be stroke prevention and symptom control, but she's asymptomatic. So there's no indication for antiarrhythmic therapy or maintenance of sinus rhythm in such a person. The AFFIRM study looked at this. They looked at mortality, rhythm control, rate control, just about the same, so you can choose. In an asymptomatic patient, there is no reason to aim for rhythm control. Now, her real risk is thromboembolic risk, and her CHADS-2 score is 0. So should she be treated with anticoagulant therapy? I'll ask for an answer from someone in the audience. Anybody in the audience? 0. So I see a few no's. Well, I'm going to disagree with that. So we'll talk about the CHADS-VASc score. So here's the risk, the annual thromboembolic risk for the CHADS score, which in her case is less than 2%. But if we do her CHADS-VASc score, she now has, she's 72, so she gets a point. She's female, so she gets a point. And she has vascular disease, so she gets a point. So her CHADS-VASc score is 3, which gives her an annual stroke risk of greater than 3%. So this is a patient, despite a CHADS score of 0, who, although we would not give antiarrhythmic therapy, we would do nothing to treat her heart rhythm, we probably should be looking at thromboembolic risk and treating with long-term anticoagulation therapy. Okay, another one. 52-year-old man with chest pain for 2 hours. Yash showed something like this yesterday. We see a wide QRS. We see P waves that march into the QRS and out the other side. So it's AV dissociated with a wide QRS, and we see QS complexes across the precordium with ST elevation. This is accelerated idioventricular rhythm. Does this patient require therapy for their arrhythmia? No. The arrhythmia is benign. In fact, if anything, it's a marker of reperfusion. It's actually not such a bad thing. So there is no treatment for the arrhythmia required. This is usually well tolerated and transient. Obviously, the main thing to do here is to maintain perfusion of the left anterior descending coronary artery, not worry about the rhythm. It is hemodynamically and symptomatically not important. So we've done this multiple times. I've shown this ECG before. We see a pause, and a pause is sometimes considered to be either a sinus pause or heart block. And this was sent to us as a sinus pause due to sinus node disease, but this is a blocked PAC. Remember, we've seen this ECG before. Remember to look at the T wave in the beat prior to the pause, because this is benign. There is no therapy needed. This is not sinus node disease. This is not AV block. There is no therapy required for a blocked PAC. Commonest cause of a pause, not a sign of conduction disease, no specific therapy. So I only have one or two more. Here's a 28-year-old man who presents with pre-excitation. He's asymptomatic, but was undergoing a physical examination, and as part of that had an ECG. And this ECG clearly shows pre-excitation. We can see that, a short PR interval and a delta wave. So do I need to worry about this patient? Asymptomatic, so I can't make him feel better. What's the other thing we're looking for? We're looking for risk, right? The only two reasons to treat a patient, symptoms, I got to make them feel better or I have to reduce their risk. Can't make him feel better because he has no symptoms, so I have to ask the question, what's his risk? So let's look carefully at the ECG, and we see one beat here that is not pre-excited. So this suggests that this accessory pathway has a long refractory period. And so this person's risk of pre-excited atrial fibrillation with a rapid ventricular response or pre-excited atrial flutter is very, very small. So I have to now balance his risk versus the risk of any therapy. Now, we do catheter ablation of accessory pathways all the time. It is highly successful. The complication rate is small, probably a little less than 1%, but his risk is small. his risk is small. It's not higher than the potential complication rate of a procedure. There are the possibilities of coronary artery damage, of aortic valve damage, or other potential tamponade. They're less than 1%, all of them, but they're not zero. So if the patient has no risk and no symptoms, we do not have to intervene with catheter ablation in this person. This is asymptomatic WPW, very small risk because of the non-pre-excited beat suggesting a long refractory period of the accessory pathway. Ablation therapy is also associated with a small risk, and that intermittent pre-excitation, a long refractory period. So first, do no harm. Remember, we don't have to treat all arrhythmias, and we don't have to treat all arrhythmia substrates. Thank you.
Thank you, Dr. Martin. You have given a wonderful account of how not to treat a patient. And we are reminded of Hippocrates, who did this thousands of years back. Thank you, sir. Any questions?
I've got one question. You showed one slide, one case of person going into vasovagal severe vagotonia. How long one can wait before taking a decision that patient needs pacemaker or dialysis?
I don't know if everyone heard the question, but it has to do with the vasovagal syncope with a long, long asystolic pause. And when would one consider pacing in such a person? And I think the answer is, I think they're generally benign, so I think you go with all the lifestyle modifications and the reassurance and the teaching them what to do first. If they continue to have episodes, and only then would we consider pacing. Remember that in the initial randomized studies of vasovagal syncope with pacing wasn't very effective anyway, because vasovagal syncope is two pieces of the reflex. One is cardioinhibitory, which slows the heart, but the other is vasodepressor. So many of these people continue to faint even after you pace them because of the vasodepressor. So I think you have to maintain blood pressure. A lot of these people have low blood pressures all the time, so I tell them to maintain their fluid intake in the summertime, or if it's hot, to maintain their salt. I think we do them, we get them to avoid standing